Good morning. Um, it's just 8 o'clock right now. I'm going to give everyone another minute or two to log in and get settled before we kick off today's webinar. Okay. I'll go ahead and start with some of my housekeeping items here as we wait for a couple more people to join. Just wanted to check to make sure that yep, we are recording, so I wanted to make sure we have that going. And introduce myself. I'm Tara Chetok. I'm the project manager for the Oregon Health Policy Board, and we appreciate you joining us today for an educational webinar on the diversity of Oregon's licensed healthcare workforce. Today's educational webinar is for informational purposes only, and so no board business or decisions will be conducted. And again, it's being recorded today so that the recording is available on our website later today for any reference back to the material shared today, or for anyone who's not able to attend, we'll have that available. And I just wanted to let members know that throughout the presentation, please feel free to ask any questions that are technical in nature or clarifying any content shared. But we'll go ahead and hold any questions that are more open-ended for discussion until the end of today's webinar. And without further ado, we'll go ahead and start today's webinar. So I will turn it over to the staff to introduce themselves and start today's educational webinar.
Wonderful. Thanks so much, Tara. Good morning, everyone. Thanks for joining us this morning. I'm Amy Clary, and I manage the Research and Data Unit within the Office of Health Analytics. And the Research and Data Unit includes the Healthcare Workforce Reporting Program. And I'm really grateful for the opportunity to share that program's work with you today. Next slide, please. First, after some brief background on the program, we'll hear from Vanessa Wilson, who will share her analysis of the diversity of Oregon's licensed healthcare workforce, and I'll let her introduce herself when she starts talking through her slides. And then after that, Mark Overbeck will talk about how the OHA Primary Care Office puts this and other data into action. So we'll look forward to hearing from Vanessa and Mark shortly. Next slide, please. And the next slide. So the Workforce Reporting Program sits within the Office of Health Analytics within Health Policy and Analytics Division. It's legislatively mandated and has been collecting data since 2010, as you can see there. The program, excitingly, has grown over the years, and we really value our partnerships with the 17 healthcare licensing boards that participate currently. And the program has data available for 17 boards, and that data spans 2017 through 2020. And next slide, please. And that data that we have available covers nearly 155,000 licensed healthcare professionals. And again, all of the boards that you see on these slides are really valuable partners in this work, and we appreciate our work with them to make this data available to all of you. And next slide, please. The Workforce Reporting Program collects data on providers' education and practice patterns and characteristics. And so what that means is our data set includes information on which providers practice where, how many providers are thinking about retiring in the near future. We also collect data on how much of providers' time is spent seeing patients versus on other types of work and other things. You can see here too, we collect data on telehealth, on Medicaid acceptance. It's a really, really rich source of data, and the source of that data comes from the surveys that licensees fill out when they're renewing their licenses for those 17 boards. I also want to mention that we have demographic data in our data set, and we're really excited to have added real D questions for surveys fielded this year. So that means that the demographic data we share today, that you'll hear from Vanessa in just a moment, is not real D data, but that going forward, that is baked into our licensee survey. So we're excited to be able to present real D data in the future. And also our data set includes good granular data on education. And go ahead, next slide, please. So we collect this data so that it can be used to inform policymakers and leaders like yourselves, and also to inform community members and the public. And on the Healthcare Workforce Reporting Program website, you can find an interactive dashboard with occupational profiles and demographic data. You can also find the two most recent reports we've done today. We have Oregon's Licensed Healthcare Workforce Supply, which was a report led by Paige Snow that came out a few months back. And then the focus of today's presentation, which is the diversity of Oregon's licensed healthcare workforce. We're really proud that we make this information available to the general public. And so I want to also make sure that all of you on this call know that if you're interested in using the Healthcare Workforce Reporting Program data, or have questions about it, or are thinking about how you might be able to incorporate it into the important work that you're doing, please don't hesitate to reach out to us. So if nothing else, remember the resources on this slide, and we want to make this data available to inform policymaking and work to improve people's lives in this state. So without further ado, I would like to turn it over now to Vanessa Wilson. Vanessa. And next slide, please.
Okay. Awesome. Sorry, 1 second. Okay, so thanks, Amy. My name is Vanessa Wilson. I'm a research analyst with the Healthcare Workforce Reporting Program, and I'm happy to be able to share this work with you all today. Go ahead to the next slide. So not sure Amy mentioned this, but this report is a recurring report produced every 2 years. The most recent iteration of this report has 3 primary objectives. First of all, what does the licensed healthcare workforce look like in Oregon? What is the racial and ethnic composition, the gender distribution? What languages are spoken by providers? What does the entire workforce look like, but also what do specific provider types and groups look like? Next, is the workforce culturally and linguistically representative of the population that it serves, specifically in this case, people in Oregon? And finally, how is the workforce composition changing over time? We now have data from some boards for over 6 years, and this is the first of these reports that we have tried to look at how the workforce may be changing. Next slide. So as seen in this chart, Oregon's population has become more diverse over the last decade. Since 2009, the population of most racial and ethnic groups has increased in Oregon. For example, the Hispanic population has increased from 10.6% to 12.8%. And the only group that has not increased over this period of time is the American Indian and Alaskan Native population, which has shown a very small decrease. The white population is not shown in this chart due to being on a very different scale. However, during the same period of time, the white population has decreased from 80.4% to 76%. Go ahead to the next slide. So this chart shows the licensed workforce in 2020 in blue compared to the state's population in gray. The state population numbers are what we just saw for 2020 on the last slide. Seen here, overall, Oregon's licensed healthcare workforce is less racially and ethnically diverse than the population being served, with whites and Asians being overrepresented and Hispanics being underrepresented. It should be noted that these are very broad racial and ethnic groups. For example, Asian is a very broad descriptor and inclusive of many South Asian and East Asian populations. As Amy mentioned, we have recently implemented RealD data collection standards, and so in the future we will have data available at a more granular level, and we'll be able to hopefully break these groups down a little bit more. This chart also masks differences seen among specific occupations. So go ahead to the next slide. The distribution of race and ethnicity does differ significantly between occupations. On the left is a screenshot of a table that is part of the complete report. It shows the distribution of each healthcare profession's race, ethnicity, and gender compared with the state's population. Differences are noted at the 0.5 percentage point level, with darker orange indicating a higher percentage in the state and lighter orange indicating a lower percentage in the state. White cells indicate a similar value between the two. So a row that is entirely white would indicate that the racial and ethnic distribution is fairly similar to the population. I'm not going to go through this table line by line. It is available in the report. Also, this report was released with supplementary Tableau dashboards. And so when you go to the report, there are links from within it that take you online to a dashboard where you can explore the data further. As I said, the table is available in the complete report, and then in the dashboards, this table is also available for prior years. So you can explore what those numbers look like. However, from just looking at the screenshot, it's fairly clear that most occupations differ significantly from the population. Also, so if you look at the first column, it shows the percentage of Hispanic providers, and a quick scan of the table shows that most occupations are lower than the statewide percentage, because they are a lighter orange. However, there are differences between occupations that can also be seen. So go ahead to the next slide. Overall, Hispanic and non-white healthcare professionals are underrepresented, and white healthcare professionals are overrepresented in almost all professions. However, Hispanics tend to be represented in fields with fewer barriers to entry, or to be more represented in fields with fewer barriers to entry in lower wage healthcare professions. For example, certified nursing assistants and chiropractic assistants are the only two occupations with a higher percentage of providers, of Hispanic providers, than the state population. Generally, there's more racial and ethnic diversity among lower wage occupations compared with occupations that require more years of formal training. Additionally, women are overrepresented in most of the professions included in this report. However, men do tend to be overrepresented in fields that are requiring more advanced training, for example, dentistry and medicine. We added the option to self-describe gender to our surveys in January of 2019. However, due to the nature of the renewal cycles, only 59% of licensees included in this report saw that option when completing the survey for the most recent data set. Of those, 0.2% of licensees preferred to self-describe their gender, and most frequently reported self-descriptions included non-binary, transgender, and genderqueer. And also note, we currently do not collect any data on sexual orientation. So go ahead to the next slide. Then just to make sure nobody has any questions at this point before I keep going. Okay. So returning to racial and ethnic composition of the workforce, this map shows the difference between the percentage of Hispanic healthcare professionals and the Hispanic population by county, with darker blue indicating a larger gap. So a negative value means that the percentage of health professionals who identify as Hispanic is smaller compared with the Hispanic population. As seen in the bar chart earlier, a few slides ago, the licensed workforce in statewide is 5.8% Hispanic, while the statewide population is 12.8% Hispanic. It's a 7% gap. As can be seen in this map, this gap also exists at the county level. The licensed healthcare workforce in nearly all Oregon counties is less Hispanic than the overall population. Just as one specific example, make sure this is clear. In Malheur County, the farthest southeastern county in this state, 33% of the county's population identifies Hispanic, while only 10% of the county's healthcare workforce identify as Hispanic, a gap of 23%. What is not clear just looking at this map is that the counties with the largest Hispanic populations are also those with the largest gap. Some of the counties that can fall into that group are Malheur, Marion, Umatilla, and Jefferson. Go ahead to the next slide. Similar patterns were seen in the composition of groups of providers that we looked at. So this chart shows a composition of primary care providers, oral health providers, and behavioral health providers compared with the population. Again, the population is shown in the gray bars as before. So primary care providers, including nurse practitioners, physicians, physician assistants, and naturopathic physicians, make up approximately 6% of the healthcare workforce. As can be seen in the chart on the left, most people of color tend to be underrepresented among primary care providers, except for providers of Asian descent. The middle chart shows a similar pattern among oral health professionals, where Asian dentists are overrepresented relative to Oregon's population, while other minority races are underrepresented. Behavioral health providers, and in our data we include psychiatric nurse practitioners, physicians and physician assistants, psychologists, licensed professional counselors and therapists, and licensed clinical social workers. They make up 8.4% of the healthcare workforce in Oregon. And among all behavioral health professionals, Hispanic and non-white healthcare providers are underrepresented. White healthcare providers are overrepresented in all three of these groups. However, the overrepresentation of white providers is especially pronounced among behavioral health providers, where people of color comprise 13% of the licensed behavioral health workforce compared with 24% in the population. Go ahead and next slide. Okay, so this report also looks at language use among healthcare providers. In 2020, 20% of Oregon's healthcare professionals reported speaking a language other than English. This chart shows the percentage of providers that speak the top languages spoken in Oregon households after English, compared with the population. So after English, the most common languages spoken in Oregon households are Spanish, spoken by 9.1%, Chinese, which includes Mandarin, Cantonese, and other Chinese languages, spoken by 0.8%, Vietnamese, and then Russian. So once again, the population is represented by the gray bars in the chart. So for example, while 9.1% of the population report speaking Spanish at home, 10% of the workforce report speaking Spanish. Looking at this chart, the workforce appears to be more linguistically diverse than the population. However, this doesn't take account for proficiency or training in medical terminology in another language, or whether or not they use the language with patients or clients. So go ahead to the next slide. This chart shows the same data, but broken down by proficiency level. So while 10% of the workforce report speaking Spanish, only 4.2% report advanced proficiency or being a native speaker of Spanish. Additionally, though not shown in this chart, only 6.8% of the workforce reports using Spanish with patients. Also of note is that while the workforce and population appear similar, this may be driven by specific occupations. For example, while 6.5% of pharmacists report speaking Vietnamese, only 0.08% of licensed counselors and therapists speak Vietnamese. And for most occupations, fewer than 0.5% of licensees report speaking Vietnamese. Next slide.
Hey, Vanessa.
Yeah.
We had a question come in. If you could just share, we had a question about where the race demographic data was collected from.
Yeah, so the workforce data all comes from the workforce surveys that are completed at license renewal by licensees. And we collect that directly. It's when they're in their license renewal, they're passed to the survey, and then they're required to complete the survey before they can return to the renewal and complete it. And the population data comes from American Community Survey 5-year estimates.
Great, thank you for providing that.
Yeah. Awesome. Then next, let's see. So this chart shows language use and proficiency level for the workforce provider groups that were shown before. In this case, the gray bars don't represent the population. They represent the entire healthcare workforce as a comparison. So 33% of primary care providers, those are the blue bars, and 31% of oral health, or yeah, keep going forward. That's perfect. Thanks. And 31% of oral health providers, the red bars, reported speaking a language other than English. That's seen all the way in the left side of this chart. This suggests they're more linguistically diverse than the healthcare workforce as a whole, which is shown in that gray bar. Primary care providers and oral health providers also report higher levels of proficiency and use with patients compared with the workforce as a whole, seen in the middle and on the right side. In contrast, behavioral health providers, shown in green here, were less likely to report speaking a language other than English compared with the workforce as a whole, and only 6.1% of providers reported using a language other than English with patients. Go to the next slide. Great. So the previous slides we've seen so far make it pretty clear that the current workforce does not match the racial and linguistic diversity of Oregon's population. The next ones are going to look at how the workforce has possibly been changing. So it's kind of a lot going on in this slide. The chart on the left shows the change in racial and ethnic composition in the workforce from 2016 to 2020. Note, as Amy said, all of these boards haven't been in the program the entire length of time. So the chart only includes the 7 boards that have been in the program since program initiation. And overall, the racial and ethnic diversity of the workforce does appear to be increasing slowly. The only group that has decreased in this period is American Indian, Alaskan Native, and similar patterns were seen earlier in Oregon's population. So earlier we saw the change in the population over time. All the racial and ethnic groups have been increasing statewide, except there was also a small decrease for the American Indian and Alaskan Native population. And I just want to point out it could be in part because of how that data is collected. The Pew Research survey, there was a Pew Research survey that found nationally that biracial adults with a white and American Indian background comprise half of the country's multiracial population, and that's by far the country's largest multiracial group. We also saw that response in the licensed workforce data when we broke down the multiracial group in terms of how they had identified. Over 30% of the multiracial workforce identified as American Indian and white. That's also the largest segment of the multiracial healthcare workforce. The Pew survey also found that this is a group whose members are the least likely to consider themselves multiracial despite their mixed race background. Now that we've implemented real data collection, licensees who identify as multiracial through identifying with multiple groups, they can identify a primary race. And so because of this, we expect that we may see increases in the American Indian and Alaskan Native workforce in future reporting when we switch to the real data collection. So the chart on the left shows the change since 2016 in providers that identify with tribal communities and communities of color, or the non-white communities that we collect data from. Since 2016, the percentage of these providers has increased from 16.6 to 19.7%, an increase of 18.7%. Over the same period, this population has increased by 7.1% from 22.4% to 24%. This does suggest that the difference between the workforce and the state's demographics may be decreasing. Go ahead to the next slide. I think Mark pointed out another group who was showing a very slight decrease, and I'll go back and look at that. So not all occupations are changing at the same rate. This screenshot on the left is another screenshot that's from the complete report, also has a lot on it, and we're not going to go through that line by line. It shows, however, the percentage of providers that identify with tribal communities and communities of color over time, that's shown in the very small line charts that are in one column of that sheet. In that same screenshot on the right side, there are bars that are used to show the average annual percent change for each occupation and how that compares to the state. On average, the state's population identifying with these groups has been increasing 1.7% annually. And so while the percentage of these communities represented in the workforce is still smaller than the statewide percentage for most occupations are showing growth in the percentage of licensees that identify with these communities. The chart on the right highlights occupations with the greatest and least average annual percent change in non-white providers since data became available. For example, the percentage of non-white audiologists has increased 16.5% on average annually. The average annual growth for most of the occupations included in this report is greater than the state's growth. Only 6 of the 35 occupations show less growth in the state. Those are actually the ones that are shown at the bottom. All others fall above that 1.7% line that the state is growing at. It is important to note that this measure indicates whether the racial representation of the workforce is changing, but doesn't capture in which racial or ethnic groups changes may be occurring. For example, the percentage of providers that identify as members of tribal communities and communities of color may be similar between a specific occupation and the population, but the providers of a specific racial or ethnic group may still be under or overrepresented compared to the population. The table, the screenshot on the left, it shows, as I said, that's showing all non-white providers. Available in the Tableau dashboards, we have the same data available with line charts and bars for all of the racial and ethnic groups that we are currently able to look at in this data. So next slide. So due to changing definitions and lack of longitudinal data, for example, the addition of naturopathic physicians to the primary care workforce, we didn't have their data when we didn't collect data from them when the program was initiated, but we just recently began. But because of these reasons, we can't compare these specialty groups of providers directly over time. So one way we are to try to look at how the workforce is changing is to look at cohorts of licensees. So these figures show the racial and ethnic distribution within each age cohort for the year 2020. And in general, what can be seen is that within younger age groups, there's a larger percentage of non-white healthcare providers. For example, looking at behavioral health, 7.1% of behavioral health providers under the age of 40 identify as Hispanic or Latino, while only 2% of behavioral health providers over the age of 60 identify with this group. This may be an indication that segments of the workforce are diversifying. However, because this data is cross-sectional, it is not possible to ascertain this with certainty, and there are alternative explanations. For example, it's possible that providers within some of the ethnic and racial groups leave the workforce earlier, either leaving the occupation or leaving to practice in another state. We'll be able to look at this more as we get more data. So that's all I have to share specifically from this report. As I mentioned, the Tableau dashboards, you can dive into all of this even in any level, in a lot more detail. If there aren't any other questions right now, I'm going to pass it over to Mark, who's going to tell us more about how the data and reporting from the program have been informing the work done by the primary care office.
Thank you, Vanessa. And Mark, just before you start, let's just take a moment to pause to see if anyone does have any technical or clarifying questions. I see Dr. Santa, you have your hand raised, so please go ahead.
Yeah, I was part of a discussion recently in another activity where there was discussion that there are significant numbers of unlicensed providers in some fields that provide care, especially in this case, mental health. And do we have any sense of that unlicensed workforce? My sense was they work for companies, so they're employees. They're not, you know, in private practice, if you will. Do we have any sense of that unlicensed, but, you know, providing services workforce?
I believe that there was a report that came out that did try and capture that. I think it came out 2 summers ago, and I'm going to take a look and try and pull that up while Mark is talking and see how much of that is included in there. Mark, you might have an answer right away.
Just a little bit, Vanessa. You're absolutely right. The Eugene J. Farley Center did a bunch of work a few years ago for Oregon around the Behavioral Health Collaborative. And in their report, they were able to summarize some estimates of the non-licensed behavioral health workforce, largely data derived from MACBO, not through the Health Care Workforce Reporting Program. And yeah, Vanessa, anything you can get to see about that might be useful for discussion later in this webinar.
And just to add quickly, thanks for that great question. Although our data set is the licensed healthcare workforce, we have just completed a survey that we fielded in collaboration with the Office of Equity and Inclusion that surveyed traditional health workers and healthcare interpreters. And so that's the first time we've done that. And that survey just recently closed and we're analyzing it now. So even though our data set in the workforce reporting program deals with licensed providers, we have started to take a look at THWs and HCIs, and we're excited about that.
Great, thanks, Amy. And is there any idea of when that data or report may be shared?
It's in progress now, so I'm hoping you know, in the coming months.
Okay, maybe another educational webinar.
Maybe.
Okay, I see that there is also a hand raised from the participants. Looks like Ebony, you have your hand raised for a question. Go ahead, please.
Yes. So my kind of similar question. So I know, was it 2 years ago now, there was a requirement that individuals who provided any kind of publicly funded service, at least in the behavioral health realm, had to be certified as like a QMHA or QMHP. And then, you know, there's that whole new kind of certification process, which MACBO is the administrator. And so I just wonder, you know, are we, because I would believe that that's a data set now, because I believe that that's where we're going to be able to then have that comparison of the individuals who are not licensed but certified as a QMHA or a QMHP. So is that information included, or is that data set included as individuals who are certified in what's being presented today?
They are not included in what's presented today. I do think we have been in contact with them to try and align their data collection so that we can include that data with ours. But as of now, I don't think it's all available, but I do think that it is in progress. But yeah, it's not included in this data.
Yeah, and I'll just, I think that that's an important piece, just because, I think that's the kind of group or the set of providers that tend to be able to provide some of our kind of racially or culturally specific services. So.
Yeah, it's definitely true.
Thanks for pointing that out, Ebony. That's helpful. I appreciate that. All right, I don't see any of their real or virtual hands raised and nothing in the chat box. So please continue to share those questions as you think of them, and go ahead, Mark, with your slides.
All right, thank you, Tara. Again, good morning. I'll introduce myself this time rather than just jumping in with an answer. I'm Mark Overbeck, the Director of Oregon's Primary Care Office, and our team within OHA provides the analysis and work to identify federal shortage designations, sometimes known as HPSAs or health professional shortage areas. We serve as the state's liaison for HRSA's federally funded incentive programs for providers, and we oversee the state-funded provider incentive programs as well. And that right now is a $17.5 million biennial investment that the state makes. And we also have the privilege of staffing the board's Healthcare Workforce Committee. And like Amy and Vanessa, we're part of Health Policy and Analytics Division, but we're part of a newish unit called Clinical Supports Integration and Workforce, in recognition of a growing focus and interest in the healthcare workforce. So I'm going to speak briefly regarding putting data into action. The data that Amy and Vanessa presented, the ability for us to obtain data, really important to inform activity and inform recommendations. When we're speaking about OHA's goal and the board's goal and the governor's goal of eliminating health inequities by 2030, we've got to have the activities and the strategies and the recommendations be informed by data. And I'm going to speak briefly on 3 ways in which this data and these kinds of data are being put into action, attempted to be put into action. And maybe, since I expect that we'll have a fair amount of time before the scheduled end of the webinar, this can be an opportunity for people to raise issues, explore questions. Have you thought about this? What about that? Would really welcome that. So the first way in which we're intending to use these data is for the development of a health equity framework and action plan for the Workforce Committee. Oh, I'm so sorry. I didn't say to go into the slides. Daphne, would you please? There we go. So those are 3 ways that we are putting data into action. The healthcare workforce equity framework. Secondly, strategies around provider recruitment and retention. And third, considering alternative shortage designations. Daphne, thanks. You can move to the next slide. Okay, great. So the Workforce Committee is developing an equity framework and action plan to guide its discussions and recommendations, to inform those, to give the context for the discussions and recommendations that are happening at the Workforce Committee table. Half of the members of the Workforce Committee over the last 6 weeks have participated in training around diversity, equity, and inclusion and bias, and in specific training practices in constructivist listening. We have listening sessions, we're calling them listening engagements, and document review planned this month and in May. And we're anticipating to bring a report, at least a draft report, to the Health Policy Board for its consideration in August of this year. Out of those listening engagements, the review we've been able to do of other hearings, meetings, reports that have taken place around where the healthcare workforce is not sufficient to meet the needs of all of Oregon's populations. So Daphne, you can move to the next slide. Thank you. Secondly, we have strategies that we are developing around provider recruitment and retention. And that's largely what we do is we have been for several years looking to help Oregon master the challenge of the supply and distribution of the healthcare workforce. As part of the primary care office's work set, we accompany the federal government on site visits to National Health Service Corps approved sites, and we offer content for those visits. And we are putting a greater emphasis on demographics of the population and population served as part of our role when we participate on those visits. Secondly, we have, as I mentioned, a $17.5 million biennial healthcare provider incentive program. The existing strategies do include preferential points in scoring for loan repayment awards for clinicians of color. The recently published evaluation showed that for the providers receiving awards in urban settings, 1/3 of them were identified themselves as clinicians of color. But recently we revised the rules to expand the resources for diverse clinicians in alternative settings. So you don't have to any longer be a provider practicing within the 4 walls of a brick and mortar building. You could be doing work in the community where you're doing your patient care and be eligible for an award. Ebony raised the QMHAs, and for historically we've not had loans and loan repayment available for QMHAs or for those non-licensed clinicians who are working toward licensure, and the rule change is now made that available. And we also, due to action of the board and the recommendation of the committee, the workforce committee, have expanded the amount of funding going directly to behavioral health professionals. And then third bullet here, finally, and not least importantly, Governor Brown and her recommended budget proposed $27.5 million in provider incentives to increase the diversity of the workforce, particularly in the behavioral health discipline. You may know that the legislature is considering substantial increases to this figure, and specific new strategies outlined in various legislative proposals, which would be implemented by the primary care office and the clinical supports integration workforce unit. And we're going to rely heavily on these data to be informed in the development of those strategies. And then the third piece I want to talk really briefly to is that while we are responsible for identifying for the federal government health professional shortage areas that fit the federal definition, the current HPSA methodology, which has in fact been around since the 1970s, is based strictly on provider to population ratios that don't take provider diversity into account. So for example, a ratio of one medical doctor to 8,000 people in Coos County may sound like a worse problem than a ratio of 1 to 6,000 in Morrow County. But if you look at the demographics of the workforce and an absence of Latinx providers against a population that is more than 40% Latinx, you start to get a different picture of what might really be a shortage and what may not be a shortage the way it's strictly conceived by the federal government. So with that in mind, we've begun thinking, talking in limited ways still to maybe there's a better way of identifying workforce challenges and gaps than the HPSA methodology that we would want to apply for the large investment of provider incentive money we're expecting this session from the legislature. We're not expecting to really get into that alternative shortage methodology until likely next year, given we anticipate a lot of work to do to develop strategies that will really meet the need of both expanding particularly behavioral health, but certainly working toward that future of a health professional workforce that reflects the populations of the community that it's serving. And that was all on the third slide, Daphne, which I'm so sorry I did not ask you to turn over, but there you go. I've been working from my own slides here and seeing the slides as you're seeing them. But the current HPSA methodology, the thinking that there's maybe a better way to do that, and then our timeline of 2022 for the actual development of the methodology, if we do that. And that's something that we'll be taking for consideration to the workforce committee in coming months. So that completes my portion. I'm happy to answer any questions about putting the data into action, our thoughts, what we have been doing, anything that people want to call out as insufficient, not focused in the places it needs to. And I think we've left a total of about 15 minutes for that and anything else that the participants want to engage in. I'll turn it back over to you, Tara.
Great. Thank you, Mark, as well as Amy and Vanessa for your presentations. They're very helpful and informative. So thank you for that. And I see, we'll now move into the portion that we can open it up for questions. So go ahead and feel free to raise your virtual or your real hand or send your question via chat to me. And I see Kristen, you had your hand raised, so please go ahead.
I did. I really appreciate this information, Mark and Vanessa. Many times you predicted, or I was like, oh yeah, I'm curious about that. And then that was the next thing you said or the slide you showed. So thank you. I was curious, kind of thinking about the overlap between you two. In Vanessa's presentation, it showed that we are making some improvements in terms, or relative to population, especially in the workforce diversity. And I was curious, maybe more to Mark, if, or if there have been any observations about, like, are we able to identify something that is helping, success stories that are helping to drive that or drive some of that change?
Kirsten, thanks so much. That's a great question, and I don't think that my answers will be particularly adequate, but I will take a shot. First of all, I want to reflect on your observation and conclusion. I hardly agree, and that we have been making progress, and at the same time, it is incremental progress, and we can't predict that that progress is going to be the level of trending upward that's going to be required for eliminating health inequities by 2030. But yes, and thank you for seeing that, because it, in some ways, I think validates the work that we've been doing over the last several years, that there is, quote, progress being made. Well, we realize this is not nearly what we need. Something we've been focused on with the provider incentive program is outreach to diverse communities, outreach to federally qualified health centers, conversations where we've spoken about the need to put equity at the core and the reimagining. And most community health centers really want, I'm clear, a diverse workforce to best serve their population. And they've had challenges. But I would say part of the progress, I can't make a causal link, but part of the progress really ought to be the work we've done to do outreach about the programs so that clinicians of color who may have a more difficult time staying in a clinic, particularly if the clinical environment is not what it needs to be, or they're serving a very challenging population to serve, there's that financial support to provide some motivation where it works, right, for them to be able to stay in a community that really wants that particular provider and their service. I will also say that I think we've just got a lot of work ahead of us, particularly in the upstream portion of the pipeline. Is frankly the two options that we have right now to diversify the workforce, to be really just cut through it all. We either need to find more diverse clinicians from other states than Oregon, and or we got to do a much better job having young people of color get interested in the health professions, supporting them all the way along the road, providing them a pathway to success so that they can become the clinicians of the future. That's my 4 cents on it.
Yeah, I really appreciate that. And I really agree with that second path. And I feel like looking, I mean, Vanessa, you called out that there are some of the lower wage with fewer barriers to entry healthcare positions, like there is interest. And so how do we lower more barriers? Because there's interest there, but we need a path. Thank you. I'll let other people.
Great, thank you, Kristen and Mark. John Santa, you had your hand raised next. Please go ahead.
Yeah, well, 2 issues, and I think, Mark, they kind of follow on to some comments you just made. I'm struck, of course, by that county map, and I suspect that what we're seeing today is a downstream report And that if we looked upstream, my hypothesis is those counties that aren't doing so well are counties that don't do well graduating ethnic groups from high school, getting ethnic groups into college and through college. Is there a correlation that with high school graduation rates by race and ethnicity and college graduation by race and ethnicity in those counties? Is that where the problem is starting?
Dr. Sand, I've not done that analysis. That's an interesting, and it actually would make some sense to me as a hypothesis, but I haven't delved into the data. I don't know about graduation rates.
Okay.
I will say that we're very excited to consider new kinds of strategies and what we've been doing so far with the provider incentive program to reach out into those counties. You know that we've been speaking for years, maybe decades, about grow your own. And I think the sizable investments that are about to be made, along with some good subject matter expertise, the timing of the urgency of the focus on equity may just give us the impetus that we need to discover what does it really take to start and maintain pathways for success. And it doesn't stop when people get into the workforce. Even if you get the interest, there's all kinds of barriers that I don't even begin to understand about what clinicians face in the clinical practice environments. And I just think we got to take care of it all, but we do have an opportunity to look very upstream and maybe get some community and engagement models together that will be more focused, more long-term than what we've been able to do so far. And I don't want to diminish any of the work that we've done up until this point.
My second question is, follows on to your comment about recruitment, getting folks to come to Oregon. I think it would be interesting to know to what degree are folks from other race and ethnicities than white coming into Oregon. Be interesting to know about how specific immigrant groups are doing. You know, we've always relied in this country from a workforce point of view on doctors, nurses, and other folks who have been trained outside the United States. And there's special immigration, as you know, programs for those. I wonder, for example, I know there's, more of a Somali population now in Oregon. And oftentimes, there's highly educated and trained folks in those populations who have immigrated. They face a lot of barriers to licensing and all, but there's oftentimes retraining. And also, I wonder, about things we could do to do better by focusing on immigrant populations, folks coming from other countries, and not just other states.
Again, Dr. Santa, thank you for that thought. As you know, we also oversee, I did not mention that specific program, but the J1 Physician Waiver Program, which is our opportunity to take 30 providers, and that is the limit federally, 30 providers who've been trained, who've come from outside the United States, who've done their residency here to be able to practice in Oregon and underserved areas instead of having to go back to their native country. In recent years, a larger and larger share of those have been from Canada, and not necessarily a non-Caucasian population, but we are always wanting to see from around the world, particularly Latin America and particularly from Asia, and we have 30. So that's what we get. And I've made a note also to do a little bit of looking, see if we can do some looking on that in-migration to Oregon factor, I think both from outside of the US altogether, but even from other states and how people are faring and how long they stay. That would be a great study.
Great.
I have a comment as well. Thank you so much for all the great information and the webinar. Very informative. I really appreciate the presentation. I have a comment, I suppose, about the data, and I understand that some of the data was collected through the American Community Survey, which, you know, I think we all know has lots of flaws in terms of its data collection and how it undercounts communities of color. So I think, you know, making sure that we even make that, we call that out, right? That this information is already like a huge undercount for communities of color. I know that the census has implemented some really great strategies for the 2020 count to try to improve that, but that's still not where we needed probably to get to. And I suppose, you know, what I think I heard was that there was a decrease within the last census count in the Native American community. And I was really surprised to hear that, because if we talk to local Native community leaders and we look at data from local Native community organizations, you would hear the complete opposite of that. So I just kind of want to make sure that we that is sort of like looked at, and that community data might be brought in when sort of using this census data. So I don't know if you have thoughts about that.
That's a great comment. Thank you so much. And I'll turn this over to Vanessa, but just to clarify, so the ACS data is what we use to set the denominator, the population of Oregon. All the data that Vanessa was reporting on in the workforce reporting, the diversity report about the diversity of the workforce in Oregon comes from our survey data. So I probably should have teed that up a little bit better, but Vanessa, is there more you want to say?
Yeah, I was kind of trying to, I think, get at what you were identifying earlier. I think that is how we're collecting the data. And I think what we've been doing in our surveys has some of the same faults as the ACS data, where we're collecting data and we group all these people into a multiracial category if they've selected more than one thing. But for example, the Pew Research study that it's from 2015 that I was talking about, the largest group within that multiracial group are people who identify as white and American Indian. And those people are not people who primarily consider themselves multiracial. If you ask them their primary identity, they do identify as American Indian. That's something that the Real D data collection, now that we've implemented, we will be able to actually see that and have that. I think those numbers will go up in our data. And I'm not sure what we'll do about the ACS data at this point for having something to compare to in the population to see how we're if we're on track or not, because those problems are still going to be part of the ACS data. OEI is doing some work to try and get better estimates for those populations because of what you're identifying, where those probably are undercounts for how people are actually identifying. But that work's all in progress right now. I am hoping that the new data collection gives us a better picture of all of these groups. So does that kind of answer your question?
Yes, thank you.
Yeah.
And then
yeah.
Oh, go ahead and finish. We had another hand raised that I wanted to make sure we got to, but if
no, go ahead. That's good.
Okay. Ebony, you've been waiting patiently with your hand up. Will you please go ahead with your question?
Thank you. Just more of some comments. So, I think it's going to take a multi-pronged approach, and the lens that I'm going to be kind of speaking to is from the African American lens. And one of the things that I think also, while it's going to take a multi-pronged approach, we have to remember too that just because someone has the same pigment doesn't always mean that person is going to be effective in treating that individual. And I'm thinking more around the behavioral health realm, just because the Black community in Portland is not the same as the Black community in Atlanta, or the Black community in Philadelphia, or the Black community in New York. And so many times I've seen where folks have come from other areas and have not been as successful just because they're not familiar with the local nuance. And at the same time, you know, people are trainable and things like that. So I just want to highlight that piece. I also want to highlight too, I love the fact that, you know, if I'm tracking correctly, not based on what was reported today, but what seems to be kind of sustaining the Black community, at least, you know, in Oregon, is the African immigrant. And so I think, you know, we, you know, now have the opportunity to look at how do we create or diversify the workforce to meet the needs of the African immigrants, and also remembering that then the Black experience is also very different. So, you know, the strategy for African immigrants is going to be very different than African Americans. And then the last thing I'll just say too is that what I find is that oftentimes Black clinicians tend to leave their work environment because of the ingrained institutionalized racism. And so it's one thing to recruit, but if your environment is not welcoming to a place where folks you know, want to stay and can be successful. So I guess I'm also saying that it's going to take a strategy of training and educating the work environment, or the larger kind of dominant culture, provider culture also, if that makes sense. So thanks.
Great. Emmy, excellent points and great questions from all members today. Thank you for your engagement. Thank you for your questions. I don't see any other questions or hands raised, and we're just a minute over. So we're going to go ahead and wrap this up. Thanks again, Amy, Vanessa, and Mark. Excellent job. We'll have the recording on the board's website later today. And also we have another webinar next week, next Tuesday at 8 a.m. on the kindergarten readiness measure that will be discussed in a couple committees next month, as well as the May Oregon Health Policy Board meeting. So please join us for that if you can. And have a great day, everyone. And again, thanks for joining us.